Bismillah ar-Rahman ar-Rahim. Uh, we will start studying another two cases of ABG interpretation. So I just reminding you that when we start reading the ABG, we have to first listen to the clinical status, which will give us a hint about the expected pathology or pathophysiology, and at the same time look at the lab investigations and radiology in order to define it. What is the expected pathology? Again, when you look at the ABG chart, this is the third point. Just come and write down the data here on this monograph. And after that, start to calculate these monitors corrected bicarbonate, chloride sodium ratio, anion gap, corrected anion gap, strong ion differences, buffer base, strong ion gap, base excess, alveolar occlusions, and alveolar arterial gradient. When you do something like that, you'll start reading. And according to the keeping in mind the clinical status, lab investigations, when you read, have to correlate and see what is the pathology, especially if it is mixed, what the patient had certain pathology and then followed by another pathology. Let's go and see. This is case number 16. When you come to this is a patient with well-state patient, 55 years old, woman, and this was admitted with complaint of severe vomiting. When you come to severe vomiting for 5 days is too much. Vomiting for 5 days. Vomiting, loss of chloride, and gain of bicarbonate. This means that severe vomiting, we are facing the problem of hypochloremic metabolic alkalosis. And at the same time, this is for 5 days. This maybe the patient may suffer some sort of dehydration or hypotension and there may be fusion. So I am expecting to have two pathology. This is metabolic alkalosis, hypochloremic metabolic alkalosis, and at the same time, this is a high anion gap metabolic acidosis due to impaired tissue perfusion. So these are the data of the patients. Look at this is a sodium, this is a potassium, this chloride is low, and the creatinine is a little bit high. And these are the ABG. When you come to the look at the let us go to the chart itself. This is a monograph. This is a pH of the patient. When look, this is a pH 7.23 from the history of vomiting and then dehydration or hypoperfusions. pH is acid. It is an acidemia. When you look at the carbon dioxide here is hypocarbia. This is hyperventilations. We come to the bicarbonate. This is metabolic acidosis. Slow on the bicarbonate. If you put in mind that this is metabolic acidosis with compensatory respiratory alkalosis, this is 9 minus 24. This will give you about 15. This is 15. Each loss of 1 milliequivalent of bicarbonate will be associated with loss of 1.2 carbon dioxide. 15 by 15, this is a 15 by 1.2 will give you about 18. So the carbon dioxide 14 minus 18, 40 minus 18 will give you 22. This is an exact compensations. So this is from this study, this is metabolic acidosis compensatory respiratory alkalosis. Come to jump. This is the sodium. When you look at the sodium, this is the sodium. It's normal or just a little bit high, maybe due to heme concentrations. Come to the potassium, it's normal. When you come to the chloride, this is 77. This is low chloride. This is hypochloremia. So the ratio between chloride and sodium is 53, normal 74. So this means that there is loss of chloride. With the loss of chloride, this concomitant compensation increase in the bicarbonate. This should be expected. But here, what about the carbonate here? This is bicarbonate is 9. No, this is the bicarbonate 9 when the patient started to vomit and so developed the metabolic alkalosis. But after that, he developed hypotension and this alkalosis becomes acidotic. There's loss of bicarbonate. Here comes the corrected bicarbonate or the previous state. The previous set of bicarbonate. This means the bicarbonate plus anion gap. Oh, this is the anion gap, which is a high anion gap. This is anion sodium, so the sodium minus chloride minus bicarbonate gives you this is a high anion gap. High anion gap metabolic acidosis. High anion gap metabolic acidosis. This is a clue. When you look at the buffer base, also it is low. Buffer base low. This is a metabolic acidosis. High anion gap, low bicarbonate, low buffer base. This is high anion gap metabolic acidosis. Corrected bicarbonate equals bicarbonate plus the anion gap minus 12. So look at this. This is the corrected bicarbonate. This is a bicarbonate when the patient was on vomiting. He was vomiting, so he was losing chloride with concomitant gain of bicarbonate. Look at this. There's no loss of sodium. That's when you add chloride 77 plus 57. This will give you 134. 134 minus 146 equals 12. This is a normal anion gap metabolic alkalosis. So this is when he was vomiting, he had normal anion gap metabolic alkalosis. But the patient became hyperperfuse, and there is lactic acidosis, most probably, which in this lactic acidosis consume this bicarbonate. So we are facing the problem of bicarbonate now is 9. So this bicarbonate is 9. That's why the anion gap is high. This is loss of bicarbonate. This is anion high anion gap metabolic acidosis. And at the same time, we look at the buffer base is low. This is also gives you a clue that this is high anion gap metabolic acidosis. And at the same time, when you look at the strong ion gap is high. Strong ion gap should be 0. This means that we have something else, which is fixed or non-fixed acids has been added, and this is that's why the strong ion gap is high. So this patient he's vomited and he developed hypochloremic metabolic alkalosis, and then developed some sort of hyperfusion, so with lactic acidosis to develop high anion gap metabolic acidosis. In addition to this, when you look at the problem, this patient was on face mask and on the room air, and therefore the alveolar gradient was normal, and he was not hypoxic, but the problem was hypoperfuse. So this is the conclusion of it. And when you calculate the water deficit, 60 by this is a body weight, 60% by the body weight multiplied by the sodium. This is current sodium minus 140 over 140 to give you this is water deficit. So this is a problem with this patient. He was vomiting, developed normal anion gap metabolic alkalosis, and after that impetish perfusion gives us high anion gap metabolic acidosis. Let us go and discuss another case. This female patient with congestive heart failure, most probably which was stable and started to be decompensated, started to develop more dyspnea, more orthopnea, and in addition to the lower limb edema, cardiomegaly, bilateral pleural effusions, blood pressure was 120/80, and this patient was on Lasix. When it came to the ER, they put her on face mask, and these are the data. These are the ABG data and investigations. Look at this. When you come to this patient, it is a little bit, this is the pH. pH is acidemia. This is 7.24. But when you look, the carbon dioxide is 60, and the bicarbonate is close to the normal, is normal. So normal bicarbonate, there's a carbon dioxide retention, and the pH is 7.24. It is not hyperventilations. Let us complete. Sometimes it's difficult to make a comment. Just wait. This is a sodium, this is hypo, this is a color, this potassium is low. When you look at the chloride, chloride is low. So this is chloride is low. Chloride sodium is 67 instead of 74. This means that the patient is having hypochloremia. Hypochloremia with Lasix. This means that hypochloremic metabolic alkalosis. So I expect that the bicarbonate of this patient, before he developed the acute decompensations of the heart failure, his bicarbonate was high in order to compensate for the low chloride. Then we come to the another part. This is what about the previous or corrected bicarbonate? Corrected bicarbonate. This means bicarbonate plus the anion gap. This is an anion gap. So look at the anion gap here is 24. 24 is high. This means that the patient is having a high anion gap. High anion gap metabolic what? Metabolic acidosis. This is bicarbonate is normal. Look at the buffer base. When you look at the buffer base, this is 41. This is buffer base 41. It is an alkalotic one. This is strong ion differences. Strong ion gap is 8. So this is this means that we have an addition of acids, whether fixed acid or non-fixed acids. This is mean that this high anion gap. This high anion gap metabolic acidosis. Metabolic acidosis. Why? Because the patient when you calculate the corrected bicarbonate equals bicarbonate plus the anion gap, which is 24, minus 12. This means that the corrected bicarbonate is 37. So the patient was alkalotic due to the use of Lasix, and this alkalosis the patient started to develop more decompensations with lactic acidosis, and the bicarbonate dropped from 37 to 25. This is a metabolic acidosis. That's why the anion gap is high, and this strong ion difference is high. This strong ion gap is high. So this is a very important one. So this is the patient had he was on Lasix. That's why he was on his state was hypochloremic metabolic alkalosis due to the use of Lasix as the line of treatment. But when he developed acute exacerbations of heart failure, this means that he developed a more lactic acidosis, more acids. This is strong ion gap, and these more acids led to the consumptions of bicarbonate instead of being 37 became 25. That's why the anion gap of the patients became high. Instead of being 12 times, it became 24. This is a very important point. Another important way, so this patient was had metabolic alkalosis, hypochloremic metabolic alkalosis due to use of Lasix, and after that developed a high anion metabolic acidosis. But what about the carbon dioxide? The carbon dioxide here is a little bit high. When you look at this patient had pleural effusions and heart failure, interstitial edema, and most probably became hypoventilated. Why? Because this is the compensation for this 25, the carbon dioxide should be 40, but it's 60. That's why when you look at this is FiO2 was 30. This means that the patient was hypoxic, and this alveolar oxygen was when you calculate 135. This is arterial oxygen. So alveolar again was high, and this is an important point. So this is a patient who was hypoxic, pleural effusion, interstitial edema, stiff lung. That's why the patient had hypoventilation. So this is the hypoventilation respiratory acidosis. So the picture of this ABG patient was hypoxic and was and hypoventilated with respiratory acidosis. Patient had hypochloremic metabolic alkalosis, is known from the bicarbonate at 7 and strong ion difference high. The patient developed acute exacerbations of heart failure with hypoxia and hyperfusion with lactic acidosis. pH dropped, and anion gap is high. Strong ion gap is high, and this is high anion gap metabolic acidosis. And the patient, this chronic heart failure should be should have hyponatremia, but most probably the Lasix. This hyponatremia is usually delusional by the Lasix. The use of Lasix corrected it, and therefore that's why the sodium was normal. And thank you.